Okay. Oh, wow. Interesting. Okay. Thanks a lot for being on this session. My name is May Terry, and I'm a principal healthcare informaticist at the MITRE Corporation. I have the wrong presentation up. 1 second. That's the right one. Okay, great. So for the topics today, we're going to start with a brief overview of mCODE because there may be a number of attendees here who are not familiar with the minimum common oncology data elements. Since this presentation is about a little bit more about the clinical genomics elements, we're going to dive down a little bit deeper into that. Go through some examples of how certain genomics-related elements are represented in mCODE. Follow it up with a comparison of other models, which might include the HL7 Clinical Genomics Reporting FHIR IG, as well as other more research-oriented models like the OMOP Genomics Common Data Model. And then we'll close out with some perhaps additional considerations of how we can move forward with mCODE and its evolution, so that we can get closer, to helping satisfy our vision for precision medicine over time. So for those who are not familiar with mCODE, as mentioned before, it's the minimum common oncology data elements. And it's a data standard that when it was created originally or conceived back in 2018, really went down to the question of, well, in particular for EHRs, what would be that minimal set of oncology-related data elements that we can have in order to help improve interoperability among providers? Again, I think the operative term here is minimal, a minimal set of data elements. And with that, we had made certain initial assumptions of making it applicable to all cancers and collected for standardized information exchange. Again, as I mentioned before, the initial release when mCODE first had its use cases, it was really meant to be this interaction between a provider and a patient that helps to identify diagnosis, treatment, and monitoring. But it has since, expanded in a way that with the vision, we can have that data element set be useful for a number of different stakeholders, which would include patients and providers, at some point in the future, payers, government and regulatory, as well as research. Again, as noted before, mCODE in some ways is a base model that applies to all cancers. And it had that limited use case. What we'd like to note too is that, mCODE is a foundation, and there has since been set up a FHIR accelerator called Codex, which in some respects is meant to build upon mCODE to have additional use cases related to oncology care. There's an additional link down here. Again, that's also important to note because as we go through some of these elements, you might have some question in mind, saying, well, why doesn't it cover this particular element? Or why doesn't it necessarily satisfy this particular use case? And that's on purpose because, we do hope that with the Codex FHIR accelerator, these use cases can help the expansion of oncology interoperability by building upon this foundation. What's nice is that, we have since, had a pretty good success with Codex and a number of partners that are available, and are interested in building on top of mCODE. So let's get to this model itself. mCODE, just a little bit of history, was originally, again noted, conceived in 2018. It was balloted in September 2019 with quite a number of ballot comments, which we had since reconciled, and it has been published in March of 2020 with the URL that is shown below, and you're able to look at that at your time. Within the front page of that IG, you'll see here a conceptual model of what mCODE 1.0 encompasses. You can see it is broken down more or less into 6 soft categories. That's not exactly stated in the IG as is, but it's really more for a visual of how you can potentially group these different elements that you see here. We start at the top left with disease, and by disease we mean cancer in particular, because this is obviously an oncology IG. It further delves down into a primary and secondary cancer condition, where the primary cancer condition could be like breast cancer, and secondary cancer condition is really more reference to a notion of metastases. And there is staging information also involved with it. And that staging information is also very generic. Potentially a stage group can apply to multiple different stage groups, stage classifications, but there are some, like in the TNM classification for oncology, you'll see that it further breaks down into T, N, and M categories that can be either clinical or pathologic. Also, if you go down to probably what I should have started with first, which is the cancer patient. The cancer patient itself does include demographics, things that are very centric to the patient. Besides the demographics, it would be things like what are their comorbid conditions, things that are not necessarily cancer specific, but are related to it. The comorbid conditions that we have created is constrained to the Elixhauser comorbid conditions, so it's not necessarily all possible, conditions for the patient. Also centric to the patient is the Karnofsky and ECOG scoring, which is a measure of performance statuses. If we go to the upper right-hand part, you'll see that there are certain elements related to treatments, medication-related, surgical-related, radiation-related, and there is also a notion of a cancer disease status, where after a certain period of time, there are particular evaluations for the cancer patient as to whether the condition is improving, worsening, or staying the same. And then for two of the key ones I will be focusing on a little bit more, to the right, dark blue, there are labs and vitals. You'll see that there is a certain set of elements related to tumor markers. And then you'll also see that in green, there is this notion of a cancer genomics report. There is a particular difference between both, and I'll get that into that in a future slide. But just note that when we think about biomarkers, these are really the two areas that we're going to be focusing on. And then just as another important note, you'll see at the bottom here that it says external profiles. Again, these are not necessarily directly, profiles that are included in the IG, but rather they are references to US core related profiles. And that's done on purpose because we want to be leveraging as many of the existing profiles that are available today within HL7. Okay. So again, this presentation is also, again, it's in the title, mCODE clinical genomics, a foundation for precision medicine. So it helps to have this working definition of at least what I mean about precision medicine in the context of this presentation. There are various different definitions, which might include like lifestyle and social determinants of health. In this particular case, we're really honing in more on this form of medicine that uses the patient's own, information of their own genes or proteins to diagnose or treat disease. So if we think about the three main types of domains of information that we'd be focusing on here, it would be on the patient, the type of cancer that they have, the genomic variants that may be related to cancer, as well as certain treatments, primarily medications that could be used, say, within targeted therapies. All right, so if you were to, again, think about this tying together of mCODE and oncology precision medicine, going back to the scope, I originally stated that mCODE was originally thought about as the interaction between, a clinical oncologist and a patient as they go over treatment options. That kind of puts mCODE into the provider clinical data realm, at least to start. But that said, if one thinks about the other types of applications and stores that are more research focused on this notion, as you go through precision medicine, at least within what I'm thinking about here, is that it almost becomes this kind of learning healthcare system where you have this initial provider clinical data, which could be at the point of capture in oncology EHRs, potentially within registries and so forth. That ends up fueling perhaps one or more research data marts, which have their own models. And then the results of that could potentially go back into these clinical applications, again, that really might be a little bit more prescriptive. There's a little bit more about that we'll touch upon later. But it's this kind of circular exchange of data between provider clinical data and genomic research data that we're really trying to reach here. Okay, so we had the original, concept model, a couple of slides ago. And if I were to just take out the rest of the things that we're not focusing on this presentation, right now, you can see here the biomarker-related elements where, again, we are kind of focusing on the notion that the patient has cancer, a currently actively diagnosed cancer. And then as a part of it, there are particular genomics related tests, as well as this notion of tumor marker. Why did we separate this? This is a common question that I get when I get shown mCODE. And in some ways, it was a very pragmatic reason. As you see here, this thing that we have in blue is considered lives and vitals. And even though a genomics report would come from a sequencing lab, potentially, there was a very pragmatic decision to keep them separate because of the way that messages would be received within a provider environment. So let's say that you could have tumor markers, which, by the way, we have kind of determined are a combination of maybe some tests that are done using immunohistochemistry, or perhaps FISH or KISH, and that you might get from a reference lab that's not necessarily a sequencing lab. And on top of that, you may also get some serum tumor markers that are used as prognostic factors. As an example, estrogen receptors, maybe a prognostic factor for the staging of breast cancer. Some of these results you might get from your, from Quest or LabCorp or BioReference, where the type of feed that you would get from these systems may be something as much as an HL7 message. Maybe it could have been translated to FHIR, but it's usually a lot more lightweight. And it would have something, maybe as simple as this is your marker for estrogen receptor status, and then the result being present or absent, or in some cases positive or negative, depending upon what the types of value sets associated with that LOIN code would be. It's a lot more lightweight. And this is different from what you can see here, say in the genomics report, where you have a lot of metadata. It's very heavy and goes further, into the complexities of what a genomics report might have, which would include potentially one or more regions that have been looked into, and within one or more regions, you may find a number of variants, and these variants could have quite a bit of information with regards to its coordinate system of what was used for the genomic region, as well as the types of change that you would find within these variants, depending upon whether they're genetic variants or protein variants or chromosomal. We have within, again, mCODE just kind of made that kind of distinction, and made sure that, again, that there might be a little bit of overlap that you would find in here, but again, the decision was kind of made pragmatically. All right, so how would this potentially work, using mCODE? And again, if one thinks about the use case of having an EHR where a clinical oncologist, I would say more often than not, is not really looking into exact sequences. They're not looking into, very complex information. More often than not, in some cases, they would be looking to see if a mutation exists and whether it's positive or negative, or whether a specific variant was present or absent. Here's a very common example of what I've seen in the past. You might say that, oh, they did this germline test and, all they want to know is that the patient was BRCA2 positive. And here's an example. This is just, this is fictitious. There's no PHI in it. And you can see that this is BRCA2 positive. So you'll see on the left side that you'll have things like the birth date, the gender, etc. And then all you'll see with this analysis is the result of BRCA2 and positive. How would that translate? Well, in this case, you could see that this is the names of, or the layperson's names of the profiles that are in mCODE. You'll see that there's Cancer Genomics Report, and then a variant, and that has its relationship to the patient. So you'll see the patient demographics, the report itself that tells you which organization is involved, the specimen, the type of specimen, as well as the collected date and time. You can see all this matching here. What's probably most important is that the result of what you'd end up seeing in the cancer genetic variant would have a value codable concept where it's present or absent, and then the interpretation of it would be positive or negative. That might have a little bit of a variation where you might have your EHR where someone could have had a drop down and just as positive or negative. In this case, mCODE, and I also think the clinical genomics reporting IG kind of considers it, along the lines of it's present or absent, and positive or negative being more of the interpretation. This is a little bit of an eye chart, but it's to show you, and I took this example from the mCODE IG, and by the way, the IG does have examples for every one of our profiles. A second representation could be a little bit more than just positive and negative, where you can look for the, represent the gene that is studied, as well as the actual variant that it found, and the notation that we use here is HGVS. Okay. Another thing that definitely comes up within the review of this IG is that there are many different knowledge bases, there are many different coding systems that could be used to represent, whether it's variants, certain knowledge bases, representation of some genes, and even the cancer type itself. What we originally had with mCODE's release is that originally was really tight, and then we realized in working with the HL7 Genomics Working Group is that there probably needed to be a loosening, because there could be quite a number of alternative terminologies that do apply within the genomic space, especially in the case if you are working, say, on the research side. So as an example, you'll see here at the top, there is a cancer type where mCODE, because a lot of it is based on US core, has a strong preference to SNOMED and ICD-10-CM. However, there are other alternatives, say in the case of a cancer registry, where the preferred terminology could be ICD-03, as in the case of FHIR. And on the research side, we've had quite a number of organizations that actually do their cancer groupings and their cohorts using OncoTree. The one probably consistency that I've seen across multiple of these models has been the gene, in which case the HGNC is preferred, and oftentimes also preferred across different models. The one thing that is probably the difference, and that is a nuance for mapping, is that mCODE kind of prefers the notation of using the HGNC code. And this has actually been found where if you just put the number, that might actually be too ambiguous, because HGNC has a certain notation that if you precede it, then it's actually the gene itself. It is very possible that if you just include the number, it may be the gene group ID. So to be explicit about it, we do, at least for the gene, request the combination of this convention, which has the colon in the middle. What you'll find, though, is that in other models, there is a tendency to have the gene representation using the symbol itself. So that is something definitely to note as we start doing comparisons. I gotta increase my time here. Again, our preference within mCODE is ClinVar, but we're definitely not limited to it. You'll see it in the IG that there are others that could be also accepted, which includes Cosmic, and that is very useful as a knowledge base for the somatic mutations of different cancers, and a huge curation of data that drives it. And then finally, what you'll find too is that there is kind of consistency in the nomenclature using HGVS for gene, protein, and chromosomal variants as well. Okay, so let's go through an example persona, and we'll kick it up a little bit more. Eve Anyone, just to give an example of how this would be represented. Eve Anyone is a 67-year-old female diagnosed with stage 3A breast cancer, and then here's some examples of prognostic factors that drove the staging. In this case, it'd be ER positive, PR negative, and HER2 positive. A different genomics test revealed that she was also a BRCA2 positive. At some point, she was started on trastuzumab on this certain date, this TBD date, and then after a while, her condition was improving. The idea behind this is that, again, as you go further to representing mCODE and saying, well, how can I use this, so I can be a bit more prescriptive on the types of targeted therapies, how could we potentially represent this in mCODE? And this is quite an eye chart, and we can go through it for quite a bit, but you can see that it further breaks down if we see the names of all of the profiles that we have within mCODE, how it fits rather nicely in its representation, where you'll have Eve Anyone as part of the patient itself. The primary cancer condition, again, based on US core condition, will have the cancer type in SNOMED with a reference to the patient, and the body site as well. As well as the clinical stage group, which we rely here using AJCC, and using the AJCC representation that you would find using their API, which tends to have, whether it's clinical pathologic, pre-coordinated with the actual code, in this case 3A. What I want to focus on here, however, is the genomics report. I gave little snippets and examples of what it would look like. This is a little bit more comprehensive. Again, only the relevant parts are shown because we don't have time to do this whole code walkthrough of all of the JSONs that have been created, but I do have a reference implementation with these examples. I'll be happy to provide that at the end. But you'll see here from the cancer genomics report, we very much mirrored it to how the clinical genomics reporting group thought about it too, which would be a slice of diagnostic report result. And we have at that point, two examples here that goes to a reference to the cancer genetic variants. So in this case, cancer genetic variant 1 will show that the gene itself is ERBB2, which is actually HER2. You'll see that this notion of present and absent would be available as up here using the LOINC code and LOINC answer lists that are associated with it. And then this genomic source class that identifies that, at least in this case, ERBB2 is a somatic mutation, as well as, although that's not in the narrative, just for completeness, putting in an example of what the variant would be noted in HGVS with an interpretation of positive. And a similar one that looks very much like the somatic mutation, except that in this case for BRCA2, it would be a germline mutation. There is a link as well to the genetic specimen, which I've noted as tissue. And then finally, to trace this, the patient is taking trastuzumab, which we have had a treatment intent, which in this case is curative. And we are using the RX norm code for trastuzumab. Again, because it is based on RX norm, there are various different term types, which we'll actually talk about now a little bit quicker to finish up. But you'll see that this term type in RX norm is a little bit more detailed than oftentimes what a number of the knowledge bases have when they recommend, like OncoKB has just the ingredients. So there would be some translation that would be needed in order to align the right ingredient level code. And then finally, we have another profile called cancer disease status. And going back to the narrative, you'll see that we do have a condition with a patient condition improved as the finding. Again, the value set specifications and bindings are all within the IG, and I encourage you to look at that. So that was nice for like a little snapshot. However, it's really, when you think about, what would be, considered an mCODE record, it really is thinking about, depends on when the mCODE data is accessed. And this is generally true, I think, in some respects for NAIG. And this becomes relevant. We'll have to revisit this soon because you'll find that, as a patient goes, only certain types of elements are kind of relevant at that point in time. Going through comparisons with mCODE and other models, there are many models that are out there, and I'm sure there are several during the FHIR, DevDays presentations that have been a really nice point of for a case study. But we have found at least some of these I've actually either directly or indirectly worked with and done some gap analyses for. But what I found in looking at these, whenever I get asked, well, how does mCODE fit with XYZ model? What you'll find is that you can see them in some respects like the way they sit on a spectrum, where some are very much attuned to provider-based use cases, and others which really go in the form of research data sets. And that would include, besides mCODE being more on the provider side, eMERGE, which is also a little bit on the provider side, but really trying to do a good job trying to bridge the provider and research side. And then there are some that are a little bit more tending towards strictly the research side, and really thinks about de-identified patient data and cohorts and aggregated data sets that come from multiple sources. And there would be things like Project Genie, you know, Odyssey, which has the OMOP Common Data Model, Argo, the GDC data portal, and even one recently I've been working with called PhenoPackage, which is part of GA4GH. The ones on the left and the provider side are so patient-centric. You'll find, again, especially as it relates to mCODE, there is an alignment with US Core, because the idea was that how would you be able to improve interoperability between providers, namely between EHRs. And then there's some, again, on the research side that are really more focused on data aggregation, finding insights, and then, you know, hopefully making those into actionable insights, whether it goes back to the provider or shared in studies. So the first one, wow, got to push forward. How does mCODE fit with the HL7 Genomics Reporting IG? Well, you could see, again, I think that mCODE is a very small subset. If you look at the HL7, you know, as an example, CG reporting IG, if you take a look at the example of the variant, you'll see that there is a lot more detail that has been included in this notion of a variant, which would include things like alleles, as well as the transcript reference sequences, certain copy numbers. There is, you know, a lot more probing information that, again, within mCODE really did not necessarily fall into the scope of, well, what does a clinical oncologist need to know in order to determine treatment options? And it really does come down to this. However, there are certain, you know, what we do anticipate is that as clinical care gets more sophisticated over time, we could definitely see more and more of the information that is, you know, being drawn in detail from a diagnostic report that comes from a sequencing lab suddenly filter a little bit more into the provider side. So with OMOP, right now you'll see that there is an OMOP common data model. I've got just a very quick picture here. You'll see that there are some elements which do have some ties into mCODE. If I look at it a little bit closer, you can see that there's a little matrix that I created with regards to the mCODE profiles that are available and what they would translate into, at least at the entity level, to CDM. What's nice about the OMOP CDM is that they do have this overarching vocabulary that is able to harmonize, you know, SNOMED as well as ICD-10 with a roll-up to a common vocabulary ID. So as a result, it kind of makes it a little bit easier to align because, you know, mCODE does have SNOMED as well as ICD-10. There are also alignments with HGVS and HGMC for the target gene. And with regards to the cancer medication statement, there's also alignment with RX norm. Another thing I thought would be very useful, and I have a demo that was in progress, I don't think I have enough time to show it, is that there is another knowledge base from Memorial Sloan Kettering called OncoKB, and they have this great API that allows you to access their curated actionable genes and possible drug treatments. So that, let's say that you're able to identify the cancer type as well as certain genes, it's possible to pull out from the API, and there would be quite a bit of mapping that would have to happen in the back. But it is possible to go ahead and have as returned something like if I pass ERBB2, which is the HGNC symbol, and then see that the tumor type, this would be a mapping to OncoTree because that's the way, you know, they have their cancers organized, as well as the drugs, which they currently had an NCI thesaurus code at least returning. There would be a little bit of alignment that would be needed. So how would that work in this case if you were to have this kind of environment where you have a provider that is capturing mCODE at the point of care, and then potentially having the, you know, the gene and the variant and the primary cancer condition, the medication statement? You could have two potential use cases where by passing it doing a mapping to OncoTree and HGNC and the NCI thesaurus. Not perfect, but this is one possibility that you can potentially go through UMLS and have the NCI thesaurus code map. It would require, however, that you take an RX norm code, map it to the term type of ingredient, and then potentially go up through UMLS and then down to see the NCI thesaurus code and potentially see if there's a match. Or if you just took primary cancer condition and the gene, you could potentially, run it back and say, here are the potential drugs that you have that might be suitable for the mutation that you have. So, that kind of leaves a segue for, revisiting the slide of mCODE and the patient journey. Again, how would you potentially, if you had, like, say, an OncoKB, type of, knowledge base that was available, and you've got this mCODE data that's being captured at the point of care of an EHR, what makes sense, right? At what point you would be grabbing this data, and where does it become timely? And that's where this slide comes in, where, as you do this mapping, does it have to be, one-to-one with every possible model that exists? Probably not. But in this case, there is kind of a minimum set that you would potentially need to look for as a patient goes through their journey to determine, where you can make best use of this. So if I had the decision, in this case, I had patient demographics and the tumor test and the variant, it is possible if I reached out to these data sets that at that point I could use it for decision support and suggest targeted therapies. However, in another case, if you were to think about that previous picture I had about the precision medicine journey, you can use it as a learning healthcare system where if you were to go ahead and fuel these research data sets, then you would have to go all the way down here at the point where you've already established a disease status and saying, was it effective? So quickly, what's next? There's some additional use cases in areas of consideration that we know, again, mCODE is an evolving, it is evolving, and we have more use cases built on top of it. Things we have been looking at are clinical significance, which we didn't capture. It identifies whether perhaps that variant is likely pathogenic, likely benign, pathogenic, benign, so forth. Other things to consider are tumor mutation burden, how to represent tumor normal, where you can potentially have multiple specimens, one normal specimen, one tumor specimen, the variance compared between both. And then finally, how could you represent fusion genes? And then other areas of consideration, again, greater realignment with, which is now HL7 Genomics Reporting IG, which is currently going through an STU2 discussion and how to improve it. So one of the things that has been coming up is the code bindings, and should we potentially have more code bindings to sequence ontology. mCODE is not considered sequence ontology at all at this time. That's something we need to revisit. And then finally, possible adjustments for research-oriented use cases. Again, mCODE is really meant to be patient-centric, and the question is, how do we better handle patient de-identified data as well as cohort identification? Finally, other activities. I have been working on an mCODE clinical genomics supplemental guide. We recognize that genomics is such a broad and deep field, and how can mCODE have a better use of its elements to apply to genomics related use cases. That is currently in progress, and hopefully that'll be coming out soon. And then finally, we kind of like to reach out to the community, because we would love to continue building upon mCODE. Your feedback is welcome, your engagement is highly welcome, as well as your contributions. And that's it. So thank you very much.
Great, thanks, May. We've got about half a dozen questions here, but unfortunately we're out of time. Wondering if you would be so kind as to work with me to answer the questions in the Q&A, and then people could come back and check in a little bit later and see your answers.
Yeah, that would be great. More than happy to do that and follow up.
Great. Thank you very much.
Wonderful. Thank you, May.
Thank you.